So essentially here we have complex biliary access. So that may include surgically altered off on the right. It may include pathology affecting the ability to cannulate, or it may even be the fact that you've failed to cannulate traditionally, which happens in a small number of cases. There's then two very important questions. Is there access to the duodenum? And is the patient having, is it benign disease or is it malignant disease that you're wishing to palliate? And that does inform one's decisions. So in high stricture with access to duodenum, we'll be honest, we still do quite a lot of PTD, particularly for bismuth 3, bismuth 4 lesions, particularly if there's a bridge to surgery, because our surgeons do favour a nice clean drainage of the remnant liver in the context of high cholangio, for example. But if you're palliating, then one can certainly consider EOS rendezvous to get uncovered stents in. And if it's left obstruction, hepatogastrostomy. People are doing right-sided hepatoduodenoscopies. I've no experience of that. Technically, a lot more challenging because you're in a long scope round in the bulb to get into the right liver with a stent. If there's a distal stricture, then using a LAMS for an EUS choledochoduodenostomy, I think has been really groundbreaking and really exciting data on that. Certainly in malignant disease, not yet in the context of a bridge to surgery, and I think ESG guidance would support the fact that this is for palliation still. If you have access to a dilated left intrahepatic, you can go with an EUS access with a needle, pass a wire through the distal or even more proximal extrahepatic stricture and do antegrade stenting. So this is pure EUS without the need for an ERCP scope. And of course you have PTD, it's still a valid option. In the context of stones, that's benign disease. We want to try and do a sphincterotomy, possibly a sphincteroplasty. We want to get traditional ERCP access there, so we're going to go with the EUS rendezvous procedure, which is a nice, elegant technique. Not easy, but certainly a very welcome technique. If that fails, then a PTD rendezvous is fine. So on the right, we have no access to the duodenum. So this may be surgically altered. Comments from Marco and Anthony Welcome as to whether there should be enteroscopic assisted ERCP first. In a hepatico-jejunostomy, that Roux-en-Y limb is shorter. In a gastric bypass for obesity, that is a very long limb and even more challenging. At UCH, we've been doing lap-assisted ERCP, and we've now introduced EDGE, so EUS-directed hot axios or LAMS in between the continuous stomach and the excluded stomach to facilitate a traditional ERCP. Nice technique. Should we be doing more enteroscopic assisted ERCP at our units? That's an interesting one. If that fails or not favoured, an extrahepatic stricture can be managed with an EUS antegrade stenting or PTD. And in the context of stone disease, still a role for PTD with SPY across. We have a case on that coming up. And again, as seen in this case, we went with an EUS HGS, but not with a uncovered stent. In this case, it was a fully covered stent that could be removed down the track.